Welcome, everyone. Thank you so much for joining us. This is the Dementia Care Aware webinar for July. Our topic today is tried and true and the new, insights into behavior management in dementia. We have an amazing guest presenter today, Dr. Sandeep Pagali, who is an associate professor of medicine at the Mayo Clinic in Rochester and the medical director of inpatient geriatrics. You'll hear a little bit more about us as well and our background. And of course, look forward to introducing myself when we get to that slide. Really briefly, again, we always do some of the logistics up top because it also gives people a chance to filter in, but just want to give a moment to acknowledge our CME and CE provider. As many of you know, we offer that at the end. We'll show you information about how to claim CE and CME. Also going to show this for a second, spend a moment just acknowledging some of our financial disclosures for this talk. Both myself and Dr. Pagali work a lot in the world of dementia, and so I've had the opportunity to work with some of the industry out there that supports dementia, but just our brief disclosures here. So logistics for this session, what some of you can expect, and of course, we fully anticipate some people will need to ask these questions later, and that's fine as well. So for all of our webinars, we use mostly the Q&A function, and we also use the chat. So both of those are available to you during the webinar. Please feel free as questions come up to put them in. We are going to be monitoring the chat and the Q&A throughout. If needed, we'll definitely take a moment to answer a question, like if it's a clarifying question. But for the most part, my job in the background here is going to be to collate those questions, kind of filter them and condense them so that we can have a really robust Q&A at the end. We will definitely have time for that. So looking forward to that. But please just get your questions out as they're coming to you and feel free to put them in the Q&A or the chat. We always put up our recording and materials on our website. So if you go to our website, you'll also see all the other recordings and materials. We've had a couple others on behavior symptoms of dementia, behavior management. So feel free to check those out. And then again, right at the end, as according with the nature of CE and CME, you can definitely claim credit for having attended this webinar. So we'll show you the information at the end of the talk. Here we are again. If you have your Zoom boxes on, you can see us as well, coming to you live, but here are our pictures. So just really briefly, I'm Anna Torres. I'm the executive director of this program, Dementia Care Aware, and so pleased to be here with you today. We always really appreciate the opportunity to bring these webinars to you and any educational opportunities. So please do give us your feedback. When you do the CME, you'll have an opportunity for that. But this is absolutely one of the greatest privileges of my career to be able to work on this program. And so pleased to have our presenter, Dr. Pagali, who I already mentioned is medical director of inpatient geriatrics at the Mayo Clinic in Rochester and an associate professor of medicine there. So we always also start off the top, like, why are we here? What are we, how do we frame dementia and sort of what are our compass points? So always do a quick review of the cognitive health assessment, and I do mean quick, but that is how we are letting people know about and training people how to incorporate early detection into care. So in order for us to improve dementia care across the spectrum of care, so ongoing care and action plans for people with a diagnosis, or just that whole process of detecting dementia and getting to a diagnosis, we really want to advocate for early detection because that gives us more time to improve brain health and slow dementia progression if people have it, and then also more time to plan to help people living with dementia and caregivers plan. So the cognitive assessment, you will find ample resources on our website to learn more about the cognitive assessment, take our online training, watch old webinars about it, but it's a 3-part assessment that takes in the 5 to 10 minute range, depending, with a brief history, which is really a question, screening tools that are validated for cognitive impairment and functional impairment, and then adding a very quick screen, if you will, on who's that person's caregiver, care partner, support system, health surrogate, lots of different ways to do that quick biopsy, but that's something we teach you how to do in the cognitive health assessment and throughout Dementia Care Aware materials. So that should be the beginning of the journey. But today, obviously, we're really going to focus on other parts of the care pathway. And this whole issue of behavioral symptoms of dementia, I think we might see Dr. Pagali reference how it can be part of a presentation. So the person doesn't necessarily have a diagnosis yet, but then it's such an issue also for us in the ongoing care, optimizing function and supporting caregivers, that whole piece of caring for people with dementia. But we more and more are sort of training and teaching to this whole care pathway. So please reach out if we can help you or your health system in any way, learn more about dementia, how to incorporate all of these pieces into care. Okay, so now I'm going to turn it over to Dr. Pagali. And again, please do put your questions in the Q&A and we'll be monitoring those and being sure to answer what we can and then bringing them to the Q&A at the end. So thank you so much, Dr. Pagali. And please go ahead and say anything else you'd like the audience to know about your work and background. Thank you.
Thank you so much, Dr. Rose. Thanks for having me here and giving me an opportunity to talk about this topic. This is definitely something that I'm very passionate about or have seen as part of my routine clinical practice over the last 10 years. And my objectives of the talk today is specifically to discuss the different methods and tools to identify and quantify behavioral and psychological symptoms of dementia, which is the short form is the BPSD, behavioral and psychological symptoms of dementia. Review evidence for non-pharmacological and pharmacological approaches to manage them effectively, and highlight the effective care transition processes or methods to optimize BPSD cares as well. And this is such an important topic because the impact of it is huge. If it is not promptly diagnosed or underdiagnosed, or we do not have the right acumen to identify them promptly, it has a huge stress, not only to the patient, family, caregiver, and the healthcare team, but all the overall healthcare system, right? Everyone, we are kind of probably chasing the wrong tail. At that point, at the same time, I would also highlight that this is very challenging to diagnose. It is not simply a lab value. It is not a simple thing to reflect on any other parameters. You need to have that acumen that it should be in your differential, right? That's one. Two, also you need to have the right tools to identify and detect this promptly. Said that, as Dr. Chodos was mentioning, sometimes this can be your earliest marker for a dementia itself. So if you find somebody who has cognitive problems, their manifestation could be a change in their mood or behaviors or apathy as such, which are all the BPSD. So those are the side effects of dementia. So it's almost a question like the manifestation sometimes can be as early as in the early cognitive impairment to mild dementia as well. So prompt diagnosis, having a good understanding of BPSD is very, very, very important, and it avoids unnecessary medical testing and definitely improves patient outcomes. So next slide, please. As you look at it, a spectrum of symptoms that we notice across different types and severities of dementia, right? Again, this is not like a standard one size fits all approach, but just a spectrum for us to reflect. More than 75% of dementia patients do have some BPSD symptoms at some point of their dementia journey. Definitely, patients, many of these behaviors are more or higher in the care settings than patients who are living in the community. I don't believe the care settings is a reason for any of these behaviors, right? But patients who have these behaviors need more help and support, and sometimes that might be a reason for transitioning to the care settings. And again, as highlighted, as you look at this, patients with mild depression or early cognitive impairment, or the mild cognitive impairment by diagnosis, usually have apathy and depression as their predominant symptoms. But advanced or severe dementias, you see more aggression, agitation, psychosis, these kind of behaviors in the moderate to severe dementias as such. So depending on the type of dementias, sometimes Alzheimer's, or we have seen frontotemporal dementias, have more behaviors. Lewy body dementias, on the other side, are associated with hallucinations and delusions a bit more prominently. Next slide, please. So this is again just a slide highlighting the prevalence of each of those some of the common symptoms across the dementia journey, right? So things to highlight are like sleep disturbances. Insomnia is really prominent. At the same time, apathy is another common thing that is prevalent in patients with dementia. Having just that awareness, things like depression, anxiety could all be manifestations of the dementia, or these are the behavioral and psychological symptoms that go hand in hand with dementia. And identifying them and managing them is very important. So, as we think about agitation, because that is one of the most disturbing behavior or symptom for us to see any patient with dementia go through, definitely diagnosing and characterizing the word agitation itself is an effort. And there was an agitation definition work group as part of the International Psychogeriatrics Association, and they have identified that agitation, rightly be used in the right circumstances for patients with dementia, that is like there is a diagnosis of dementia, so persistent or recurrent behaviors for 2 weeks with especially excessive motor, verbal, or physical aggression that is resulting in significant impairment in interpersonal relationships, social functioning, or daily living activities. And this is not associated with an other discrete psychiatric disorder or substance use, right? As you think about it, this is mostly related to dementia, and these agitated behaviors are also affecting their functional aspects. So it's again going back to the basics of how do we diagnose dementia and the impact of dementia on the functional status, right? So things to think about when we use the word agitation as part of dementia progression. When we are trying to assess and manage the BPSD, always the first important thing in a hospital setting, or sometimes if it is in a setting of threat or emergency, make sure safety is first. The patient safety and the caregiver safety is accomplished. But said that if you're in an office setting and we are thinking about apathy and depression, mild dementia, it is important to go through the medical history in detail, obtain a good psychiatric history, get a sense of the cognitive and functional baseline, and then try to define the behaviors, just like as if we do something like defining pain for a patient who is in pain, right? What is the timing, onset, severity? What are the precipitants, and what are the consequences of these behaviors? How is it affecting the functionality? So definitely characterizing the behaviors is an important first step in the history part itself. And then as a good clinician, doing a thorough review of the medications, identifying if there are any culprit medications that can be exacerbating the behaviors or making the cognition worse. A thorough physical exam to rule out any abnormal findings. Are they in pain? Is there a particular source or trigger for these behaviors noted on physical exam? Is there a new infection? Things to think about. And then accordingly, based on it, a targeted medical evaluation, like if you want to pursue any additional diagnostics to identify your clinical workup for your exam, correlate with your exam findings. Next slide, please. So the dementia progression is really considered, if you go back to the basic pathophysiology, is an imbalance in serotonin, dopamine, and acetylcholine. An imbalance of these three hormones is what really goes in the brain as dementia progression occurs. In addition to this, there are environmental factors and other comorbidities that can exacerbate the BPSD symptoms, especially if somebody is in a new environment, a lack of stimulation appropriately, or there is significant caregiver stress. They all add up to the precipitation of the BPSD symptoms. At the same time, new infections, sensory deprivations, or polypharmacy, or new medications, or sometimes not even need to be a new medication, but an old medication with that needs that needed further titration in the context of hepatic and renal function evolutions, are all things to consider as well from a BPSD assessment standpoint. Next slide, please. There are different models that have been well tested or I would say more as a framework to help clinicians guide through the processes, right? Depending on which model you adapt, I would say like don't hesitate, try different models, think about which model like makes you feel comfortable and test it out. All of these are proven models that help as or serve as good frameworks for clinicians to both assess and evaluate BPSD symptoms. The first one is the DICE model, which is describe the behaviors, investigate the cause for it, create a plan, and evaluate the response for the plan. The second one is the Wisconsin STAR method, where if you're trying to identify the causes for delirium, you try to characterize them into different categories with the person being at the center. And you try to have a visual understanding of all of these factors in one screen, and then try to make a plan effectively based on the information put together. And then there is the register, assess, reflect, the race, the time based thing, which is also looking at having a multidisciplinary case conferences, gathering as much as information possible, then making an effective plan together. And there is the IPA, that is the investigate, plan, and act. Again, different frameworks that are well published, validated tools. So definitely encourage considering using these frameworks whenever you're seeing a patient with dementia or suspicion of dementia-related behaviors, irrespective of the care setting, either it be in the outpatient, inpatient, or in a care facility. These are validated tools that I would encourage you to consider to use as well. And the next slide. So this is a quote that I would definitely highlight the importance and value of it in BPSD assessment, specifically for the fact that you can't manage what you can't measure, right? If you don't know the impact of your care plan, how would we know that it has helped or it has not helped? One. Two, if it did help, do we continue it? For how long? And when do we stop it? So to get a good sense of this, we need to measure it. And there are tools to measure the behaviors overall as well. So next slide, please. And for the BPSC specifically, right, depending on the location and time, there are about 83 different scales that do exist to measure and quantify BPSD. And I would say this is a good and a bad problem, right? The good problem is it highlights the importance of the problem and the lots of research that is happening to create these scales and tools to quantify BPSD. So if you don't like one tool, like pick a tool out there that is available to use it. The bad thing about this is like because there are 83 tools, one thing that is proven is like one tool does not fit every single care setting, does not fit all patients or all practices from a time standpoint, from a workflow standpoint. So the limitation of it is like there is no one gold standard tool or a scale that you would say this is the only one that you would use. I would highlight at least 3 tools that I have used in my own practice. The other thing is always be cautious about the copyrights of these tools, and definitely when you seek permission, many of them would want you to use their tools. That is one way for them to get advertised, I guess. All right, so make sure you use what fits best for your practice. I have used Cohen Mansfield agitation inventory. It can be used in any care location. Usually takes 10 to 20 minutes. This is probably the one thing I would also highlight here is like this is not a tool that I would assess every shift in the hospital. There is lesser value of doing that, and it is very tedious in that practice. So this is something I would think about for once a week assessment in a care facility or in a hospital setting, or once every 2 weeks, depending on how the progression is. On the other side, the neuropsychiatric inventory, which is the NPI, is a validated tool and heavily used in psychiatric clinics and can be used in office practices, equipped for 7 to 10 minutes to do the NPI. And then finally, there is the other one that I have also used is the dementia observation system. And this is predominantly in care facilities where there is shift-based work on day-to-day variations that need to be better documented and captured. And it takes about 5 minutes to complete, to check box the screening system. So I have few slides highlighting these tools as well. So next slide, will show what a screen would look like. And so this is the Cohen Mansfield agitation inventory. There are 4 bolded domains, and this is a 1-page 29 questionnaire item. And you can see how the severity of these behaviors, basing on the frequency of the behaviors, that is the columns that you're seeing 1 to 7, the more number of boxes checked for each row, if you have a higher score, means the behaviors are higher. They're occurring more often, more frequently. If the behaviors are scored low, means that behavior is not happening at all or at a lower frequency. So this is a quick summary of overall behavior, both frequency as well as what behaviors specifically are occurring, right? If you're talking about aggression, if if you look at the bucket of or the domain of the aggression here, physical aggression as well as verbal aggression, non-aggressive physical behaviors and verbal behaviors. So really the behaviors, you can characterize them in these 29 features across the questionnaire. So that is one of the strengths of it. Next slide, please. So this is a dementia observation system. And if you're thinking about looking at every single day or every night or monitoring it by the time, right? This goes on from a 24 by 7. So there is a page 2 to it. You can check box, and in each box you can write which number, which is a behavior that is listed across these 8 behaviors that are available in the top column here. So that is also a very practical tool. And many studies have been published using the dementia observation system, especially from Canada as well. Next slide, please. So as we identify these behaviors, as we talk or notice the frequency of the behaviors, we have to come down to the management of the behaviors, right? What I would really categorize the behaviors into 3 broad categories. There is a non-pharmacological interventions. And then there is the neuromodulatory interventions, that is a transcranial magnetic stimulation called the TMS, transcranial electric stimulation, that is the TES, and the electroconvulsive therapy, that is ECT. And finally, definitely we'll also mention a little bit about the pharmacological interventions to manage these behaviors. Next slide. So non-pharmacological approaches are best practice guidelines that have been established in practice, and all the articles that I'm going to highlight or show here today are all within the recent last 1 to 2 years. If you go back into literature, there is less research about non-pharmacological approaches only for the fact that this is established and is best practice. So once it is best practice guidelines, all societies have adapted it. There is no further research specifically testing and saying that is it valid or is it helpful or not. There was still one study that was published, and this is a network meta-analysis of different randomized controlled trials looking at multiple non-pharmacological interventions and looking at the impact of it on the BPSD. And what they identified in this study was exercise plus treatment as usual may be an optimal non-pharmacological intervention for improving the overall BPSD. Right? So in this, they kind of highlighted the value and role of exercise. But in general, non-pharmacological interventions beyond doubt are the first line care for all of these patients. And as we talk about, it really depends on the BPSD symptom, right? If you're talking about apathy or if it is depression, you would still encourage what are aggravating or alleviating factors and try to address those triggers promptly first. Set that next slide, please. As we talk about the neuromodulatory interventions, I would highlight that a lot of active research is happening across the nation. And this is something that we have done a systematic review and meta-analysis looking at more than 188 studies. And the conclusion of this is the TMS itself the transcranial magnetic stimulation has shown significant improvement across the studies. This is a systematic review. So in this review, we found that TMS has good effect on cognition. So if you're noticing this mild MCI patients or patients with early dementia, is there a value to help them with an additional neuromodulatory stimulation? Right, so something to kind of keep our eyes and ears open about these modalities and leverage if they're available in your community as well. Next slide, please. The other aspect, the TMS itself specifically in treating BPSD symptoms, another systematic review definitely says that this has shown benefit to manage BPSD symptoms as well, especially for individuals with apathy. So again, something with early dementias, we do see a lot of apathy there. So TMS has been proven beneficial in that specific patient population. What is still being tested is the dose of TMS, the duration, and the frequency. There are different modalities of the TMS therapies. Like, do you give the magnetic waves as a continuous therapy, or do you give intermittent burst stimulations? So that is the minor nitty-gritty details of TMS, but those are being actively tested and studied. But TMS itself has shown benefit. Next slide, please. And this is another systematic review from JAMA in the last year as well, talking about transcranial electric stimulation. This is also another study that a group from where I was involved did a review and meta-analysis highlighting that the TDCS, that is the transcranial direct current stimulation, has been effective in improving depression in patients with dementia-related behaviors as well, both with medical causes as well as the psychiatric comorbidities. So something to really think about as transcranial electric stimulation as an additional option for some of the management within these patients. Next slide, please. With that said, the other proven study, which is again another systematic review looking at multiple studies, highlights that electroconvulsive therapy for patients experiencing the agitated behaviors and other behaviors of behavioral and psychological symptoms of dementia is also proven beneficial. What they are again studying further in this specific space is like what is the treatment duration, treatment dosing of the ECT. Those are things that are still being fine-tuned, but ECT itself has shown improvement in BPSD symptoms. Again, next slide, please. That said, I think the most common thing we always go back to is as clinicians, we think about the role of medications as such. In general, again, highlighting here another publication in the last year that looked at antidepressants as such to see if it will have an overall impact on the overall BPSD, right? And in particular, agitation. Does antidepressants treat agitation? And I think in this study, there was no clear evidence of a beneficial effect of antidepressants on agitation. When I mention this, I want us to think about it in a grain of salt, especially if you think about treating agitation with an antidepressant, we probably know like that might not really work. But if the feature is depression, right? If we identify that the behavioral symptom specifically is depression, then it is completely okay to use an antidepressant in that specific patient population. So the take back message for me, at least from these studies and looking at all of it, is like you can't look at all the symptoms together and say like one pill can fix all the symptoms or most of these symptoms. The answer is no, right? I think it doesn't need we don't need super science to tell us that. We practice like patient-centered, problem-centered approach, and there is no one magic pill that fixes all the BPSD symptoms together. So we have to identify the behavior and then target the behavior particularly with that respective treatment choice or modality to handle that problem. Next slide, please. The other agents, I think commonly we do see this in practice, is the off-label use of antipsychotics, and what is the FDA label or warning about the antipsychotics is the concern about major adverse cardiovascular and cerebrovascular events, what was called as in this paper as the MASI, and its impact on patients with behavioral and psychological symptoms. So in this study, it was very interesting, and I think if you are interested more to understand the antipsychotics, I would encourage you to read this article. The use of antipsychotics at high doses was associated with a greatest risk of an adverse medical outcome in older adults with dementia with concurrent behavioral symptoms. So antipsychotics, higher doses were used in patients with behavioral symptoms, and there were adverse effects as well. So when I think this paper highlights that whenever you're using or doing something like that, there should be close monitoring for cardiovascular and cerebrovascular events. Again, this is not something that is new, but it validates the concern about antipsychotic use and the potential of cardiovascular and cerebrovascular events. And said that in my practice, something that I always go back to is if there is a caregiver or a patient safety concern amidst these behaviors. Unfortunately, if there is no other choice in that emergency situation, we do use the antipsychotic behaviors, and I always go with the concept of lowest dose for the shortest duration possible, and definitely document the safety concerns they were in, where non-pharmacological approaches were not helpful, what were tried, and hence the last resort to keep them safe is where you're using this. And I always discuss with the family as well that, hey, this is an off-label, but I don't unfortunately have any other alternative choices, and we're trying to use it for the lowest dose, shortest duration to keep them safe. And this is a time I also think about having an effective goals of care conversation, understanding what matters to the patient the most, and the caregivers the most, and sharing sometimes like probably we don't have a magic fix for these, and sometimes time as well as keeping them safe so that we can give other additional treatment modalities more time to support them. But one thing from a clinician perspective is these medications should not become a lifelong medication for the patient. It should not stay on the list forever, right? We should closely monitor the behavioral response and then promptly discontinue if we ever have to use a low dose, and then reassess the behaviors as well again at that point. Next slide, please. That said, I think something I have seen in practice, and many of you might have also seen, is the question about anticonvulsants. Is there a role for anticonvulsants in dementia management, and especially for these behaviors, the BPSD in dementia? And a systematic review here says that it is unlikely to be effective, though the studies here that were included in this systematic review or what existed in literature were of lower quality as such. So I think at least the take-home message is anticonvulsants, like if you're thinking about valproic acid, does it really help BPSD symptoms? And I think, at least for this review and what we have seen, less likely to be effective as well. Next slide. So thinking about transitions, right? I think these are patients who need to access care for various reasons. And unfortunately, in our siloed healthcare system across care settings. And what I mean by that is like we have an office practice, and I think clinicians practicing only in the office, clinicians focusing only in the care facilities, the SNFs, and then we have the hospitalists who live in the hospital. And across these care settings, as the older adult navigates their journey, there are many factors that happen in these transitions that information gets lost, and additional efforts need to be in place, especially for this vulnerable adult population and the caregivers. The caregivers are equally vulnerable with all the information given to them, the stressful journey that they have to navigate as along with the dementia, with the care transitions part. Sometimes they are overwhelmed, and information can also not reliably be delivered consistently. So leveraging healthcare by effective health records, documentation from a clinician standpoint, or if it be sometimes picking up the phone and talking to the next clinician, or sending an additional email through your appropriate channels, like effectively through your workplace emails. Those are all important things that I would encourage to consider for caring for these patients across care transitions. Even if it is in the same care facility, right? If you think about a person living in a memory care facility, and for any reason there is a nursing staffing change, or there is a new staff on the team, or the patient has to relocate to a different room within the care facility, these are considered as micro transitions, and micro transitions do happen even in the hospital. Think about somebody moving from the emergency room to the ED, from the ED to the ICU, and the ICU to the floor. Sometimes care teams change with these transitions. Care teams change based on shifts in the hospital. So lots of information. There are micro transitions within the transitions, and these micro transitions can also be very powerful and impactful for patients with dementia and BPSD symptoms specifically. If we don't know what has helped, what has worked, what is the best thing for a particular patient, we are putting them at a risk for more and more negative outcomes. And effective care transitions by communication, documentation is crucial to mitigate some of this. Next slide, please. So how do we do effective care transitions? Again, it aligns with one of the core values that I believe in is the age-friendly health system 4M approach. The 4M's standing for what matters to the patient, the medication management, identifying the mentation aspects, and mobility. And I always frame my note trying to identify, because it helps me put all of these together on a visual format and also a quick reference. And then I base my plan on these four components together, and then say, hey, this is the care plan basing on the what matters with patient, putting the patient and what matters to the patient in the center of all of this care processes we do. And then again, as we do this, it's about a good documentation. I don't want this to be buried in a discharge summary from the hospital that could be 20 pages long, right? You need to put this the bold upfront. It could be very small and brief, but I think a good documentation makes it or is very important and is helpful for an effective care transition. The same in the outpatient setting. If it is part of your routine once every few months office visit, make sure it is highlighted and bolded in the right sections that can catch the attention of any reader looking back at that note as well. So documenting in the right sections and highlighting it is very important. So the effective care transitions also like starts with promptly identifying these behaviors. What are the baseline behaviors? What are the triggers? What helps and what doesn't? And definitely in the care transitions, right? These should be patient centered and caregiver focused. As care transitions happen, sometimes it is still important that we tell this to the caregiver, but just not rely or solely on that as the only modality of communication. Definitely assess burden and fatigue of the caregiver, right? If you sense that there is a lot of caregiver burden and fatigue, that is something to acknowledge and support them appropriately. A caregiver situation where there is a lot of burden and fatigue is not successful setup for BPSD management. Caregiver stress is associated with increased BPSD symptoms as well. So definitely try to identify that and recognize it and provide resources to support it. And this can be accessed. There would be community resources depending on the system you are in. The CMS guide program is an additional wonderful resource if your organization has signed up for the CMS guide program. At the same time, for places who do not have it, look at resources that are available, senior services, what other or dementia groups or networks. These are all things that do exist in different communities to leverage additional help to support patients with dementia in their home setting specifically. So I think that the next slide would be kind of mostly our take-home messages for the last few minutes that I did highlight. And I would want to really leave some time for you to reflect, share some comments or questions that I'll try to answer as well. But summarizing some of the quick take-home messages from my talk so far would be quantifying and assessing BPSD is very important. And there are several benefits, including improved patient outcomes. So definitely this is something to consider and do it regularly. There are structured models such as the DICE, the Investigate Plan Act, that is the International Psychogeriatrics IPA framework, the Wisconsin STAR, and the time methods that can be leveraged to help assess and manage the BPSD symptoms promptly. There are scales to quantify BPSD, and some of the common tools are CMAI, the Cohen-Mansfield Agitation Inventory, the Neuropsychiatric Inventory, that is the NPI, and the DOS scales. Next slide, please. And BPSD management should be based on specific symptoms. There is no one pill that fits everything. So identify the symptom. Is it apathy? Is it insomnia? Is it depression? And try to target your management on those specific symptoms. Individualize the strategies, right? There is no one, as we looked at it, it's not one size fits all. So look at the strategy with the patient in the center, what matters the most, and target the non-pharmacological approaches as always the first line. Medication use might still be needed, and definitely when you use medications, monitoring is important to assess the benefit of the medication. At the same time, medication does not need only mean adding a medication, but also think about deprescribing or reviewing the medications thoroughly and eliminating medications that could be a culprit as well. Next slide, please. Also, something very promising and on the horizon, and many healthcare systems are leveraging right now, is ongoing research about TMS, that is the transcranial magnetic stimulation, TES, transcranial electric stimulation, and electroconvulsive therapy as treatment options for BPSD, that is specifically for dementia behaviors as well. So many research studies have been published, reviews have highlighted the value and benefit of it. So if it is available, something to also leverage for sure. And of all of this, as we do care for these patients, effective care transitions, highlighting or centering around the age-friendly health system with communication as the backbone is very crucial. Again, I think those are my key take-home messages. Thank you everyone for your patience. And I think next slide would just give you my contact information too. So please feel free to reach out if you have any questions on anything I might have said as well.
Oh my gosh, thank you for making yourself available and sharing your email. Thank you so much. That was like a very efficient, you got a lot of information in. So I'm really grateful because we have some great questions in the chat or the Q&A, I should say, and would love to get to those. So I'm leaving up Dr. Pagali's email for one more second. So I'll stop share for a second. So the first two questions really focused on inpatient, and I'm so glad they did because you're the perfect person to ask. The questions really were about the night shifts and the inpatient team, the nursing staff. What would your guidance be for those situations? Because the hospitalization itself is so triggering. People don't have time. These are very busy moments, particularly at night when often staffing is a little lower. Across units, shifts, people feel quote unquote completely unprepared. So that's going to lead to overuse of sedating medications or restraints. So anyway, I think you probably know the picture of this clinical scenario very well. So what would your guidance be about supporting the workforce in those scenarios and, achieving better care?
Well, thank you so much for that question. I think I completely agree with that reflection. That does happen in clinical practice. That is a challenge. One project specifically that we have done here in our healthcare system at Mayo Clinic Rochester, in one of our units, we started it as of a pilot and now expanding it across the whole of the medical units, is emphasizing the value of quantifying behaviors. And quantification helps us in shared awareness across teams. At the same time, as soon as nurses, clinicians start thinking about what are the behaviors and trying to understand the frequency of the behaviors, and also documenting in their nursing care plans as well as the clinician care plans what has helped the patient, that has really shifted our management and has improved patient outcomes. Initially, it is a culture change. We have not been used to that in the hospital settings, just for all the reasons we have highlighted. But what has been, I think, probably reflects a little bit is you can't manage something that you don't measure. Really applied to us, and we saw the value of it. Once we started measuring it, all of us were able to really identify what are the best plans that were effective for those specific behaviors in that patient. In the past, prior to this, clinicians were just writing all of our strategies like open the blinds, keep the patient up in the chair, feed the patient, make sure walk safely, get them to the bathrooms regularly. These are all things we used to document on every single patient. But it only gave a documentation fatigue for the clinicians, as well as like anyone reading it, nurses were not specifically having a tailored, individualized plan for the patient. That limited the efficacy of the care as well. And added to, probably, definitely, I would not disagree, probably added to more medication use in the hospital, resulting in prolonged stays, more somnolence, more side effects. But I'm not saying that all of it has gone away just with the effective assessment, but assessment has moved the needle for us. It has helped reduce frustration from staff. It has promoted excellent handoffs. Now, instead of just using the word agitation, a new nurse that comes on at night does not need to fear what is this agitated behavior that I'm going to walk into. They know exactly that this agitated behavior is wandering, or this is a person who's going to hurt or swing their arms or legs at me. So I better be at caution. So an effective communication made a huge impact, especially more of our staff now feel like, okay, they don't have the same fear of handling a patient with BPSD because they're challenging. The fear comes from the challenge because these are complex patients, complex situations. Again, definitely it's not I think I resonate with what you have said. It is a challenge, but I believe that assessment and education about this will make a difference and an impact. So definitely, if you're as a leader in your healthcare organization in the hospital practice, take time and effort to put in some modules or information about BPSD, some of these tools that are available that can be integrated into your practice in the hospital. It will also help facilitate early discharges from the hospital. We have seen that for the fact that I'll give you a simple example. We have used the Cohen-Mansfield agitation inventory as part of our testing. On the day of admission, we had a patient who had multiple fives and sixes scored, that is, behaviors happening multiple times a day, both in the physical aggressive domain as well as physical non-verbal domains, right? Both of them aggressive behaviors highlighted. We installed some, we identified the causes, we kind of had some treatment care plan, and then reassessment. Yes, the clinician notes, the hospitalist notes, especially, I think I'm equally guilty of this. We are all in the healthcare system. Our notes gets pulled from one day to forward, and the word aggressive behaviors continue in the notes every single day. But when there was quantification, what we identified was, we noticed that significant improvement in those behaviors. Now that the behaviors which were happening like once or twice every day, now they have downtrended to like twos and ones after our care plan within a week. And we were able to communicate that effectively to the care facility, mentioning the improvement in these behaviors in terms of frequency and severity. And the care facility was able to get the patient back to their care facility with the new care plan, and they were able to continue their cares. So the hospital length of stay also really improved with assessing these behaviors and then making a tweak into our care plan based on our assessment. So thank you. That's a wonderful
Yeah,
question.
that's a really, well, I just love it because it's a really like potent example, and also just a great, like, you're really reinforcing this idea that it turns out if we measure and we're a little more quantified about the behaviors, it really helps everybody get on the same page, actually treat it less as like general agitation. They need an antipsychotic, and actually like implement interventions that are addressing the actual behaviors. So it seems like, and you guys try to pilot, you're obviously doing research, so very structured as well, but using a tool, so communicating very specifically, and then maybe trying some pilots at some of these units to see what works for that institution, what like tool might use. So anyway, this is fabulous. I hope that was really helpful to the people who asked those questions. We've got a couple more, which I think are really interesting. So maybe a little bit quickly, do you know of any evidence for fish oil, DHA, I think it was, yeah, for BPSD. So it's kind of like a yes or no. And then also, if you could just say a teensy bit more about the logistics, the burdens of using some of these newer therapies, the ECT, the TES, the TMS, because I also, like, that was totally new to me, and it's nice. It's really interesting to think of this future where we're using these interventions. So just like a little more detail about that. And we still have more questions.
Absolutely, thank you. I would admit that I did not come across strong literature to suggest that addition of fish oil would impact or improve BPSD significantly. So I have not come across that literature, but also at the same time, I did not do a specific deep dive on it. So from my practice, I do not add fish oil for patients with BPSD. I want to be very transparent about that. That's one. Said that, I would definitely highlight my own individual practice experience as well. And I can share, we do have some active studies happening here at Mayo Clinic where some of our patients were enrolled in some of the studies with ECT. And I'm a co-investigator in one of the studies with the transcranial magnetic stimulation as well. And as part of these studies, what I've seen is there are improvements in their behaviors. It doesn't become like it doesn't. None of these would reverse dementia, unfortunately, but it improves the behaviors at least to some degree that improves quality of life. Again, we are doing research studies on trying to assess the quantity, the duration of these treatments, and that is something that I think is still actively being fine-tuned, is what I would say. But ECT itself, or TMS, TES, across studies, as noted in the systematic reviews, have proven benefit. And many of these are simple office-based procedures. For example, ECT is established practice for depression, for psychosis, in the psychiatric teams, like they use ECT on it's almost like just going to the dentist, right? You go there, get a visit and come back home. The same, it is done as an outpatient. They can get this done and then go back home. So ECT is the same as transcranial magnetic stimulation. I wish I had a picture I could have put on the slides, but this for you to visualize as I'm mentioning this, it almost looks like it's a dentist chair. You just go back and recline into that chair, and then there is a small cap. There is a cap with leads on it. It is a non-invasive procedure. It just sits on your head, and the magnetic waves are sent. That is the pathways are the magnetic waves will help with the brain stimulation. So nothing invasive. You just have to go sit in a chair. You can listen to music. You don't have to be sedated. You can just relax. And it is all done in 10, 15 minutes duration treatments. And then you go home. It is not something you need to be hospitalized for. You don't need any additional treatments. And then depending on, like, definitely as any other treatment, the side effects, right? Some of the side effects that are commonly reported in literature is headaches. Sometimes people have some small headaches, and these are all transient. In these large systematic reviews, what we did not see is any major concerns or major side effects with these neuromodulatory treatments. So very reassuring, very promising. And especially, I think if the side effects is a transient headache that you might have taken a Tylenol or it is resolved in the next few hours, like 2 hours or 4 hours or 6 hours, whatever that be, and there is improvement in the behaviors, I think that is completely reasonable and worthwhile is how I would look at it. And it has helped many of my patients in advanced dementia with agitated behaviors, help them at least. There is a lot more emotional distress for the caregivers, especially the family caregivers, to see their loved ones go through this rough patch. The neuromodulatory treatments are helping at least alleviate some of that discomfort, distressing behaviors as well.
Thank you so much. And so everybody knows the CME link is in the chat, and I'm trying to bring the slide up as we keep chatting here. The other question, that was really helpful. That gave me a much better picture too. I realized I did not really know much about it. I guess one quick thing, when we're talking about exercise for BPSD, do you have any recommendations about, like, thoughts about cultural competency around the non-pharmacologic and exercise interventions? And then I'll just put it out there, the rest of the questions are, I would say, if we put them together, things about, like, other considerations like alcohol use disorder and developmental disabilities, or SMI, autism, schizophrenia. Like, do you think about things differently? Okay, so exercise first, or sorry, cultural competency first, and then those questions about some of these more complex multimorbid folks.
Thank you again. Very important, and I think this really fits well into the age-friendly health system approach. I would believe not. I mean, this needs to be individualized for the patient, right? I don't believe a standard exercise comment to every single patient is the right answer or the magic solution either. But for patients where mobility is a new concern or ongoing exercise is beneficial, right? Somebody who is very mobile, exercise is always an added benefit, is what I think the studies have shown. Said that depending on the severity of dementia, if they are somebody who is early in the spectrum, the MCI, the mild cognitive impairment, early dementia, definitely, I think these are individuals who are able to do exercise. So encouraging them exercise is always a good thing that might preserve or has shown to delay cognition, worsening of the dementia progression as well. On the flip side, I don't think that can be a recommendation for somebody who has advanced dementia, who's not able to safely ambulate. Those are always barriers and challenges. So always think about placing the patient in the center of your care plan, and then highlighting the recommendation based on the individualized treatment plan. And I would actually carry the same forward, right? The age-friendly health system approach. What matters? We talked about multimorbidity conditions, different multimorbid conditions that can make things even more complicated from a cognition standpoint. Identifying them is important, and then really balancing, like, what are their medications, as well as, like, what is their specific what matters to that individualized patient and their family caregivers. I think that should be the care focus. Once we identify that, I believe we will have a good plan subsequent, irrespective of which comorbid conditions do exist. Definitely, each comorbid condition is only an additional layer of complexity, without a doubt. And but understanding those comorbidities, but still focusing on what matters to the patient, and then tailoring your plan to what matters, makes a huge impact, and I think would give us a shared decision making plan together with the patient and family, or making the family and the patient feel empowered in this journey. Because one thing that dementia patients struggle with is losing their independence. But as a clinician, if we take the strategy of what matters to the patient and putting it in the center, I think it empowers them and make them feel much more compliant, as well as, like, gain confidence back in their care team and the care management together. So some things to reflect back, but um,
Yeah, kind of looking across all these domains and sounds like what we all advocate with the age-friendly health system of a more holistic approach. Well, thank you. Okay, so last questions I think also are really relevant to your talk, and I think we have time to get to them. Recommendations for improving communication across clinicians in large health systems. And one thing I heard you say early on, so I'll just reiterate it, is ensuring that like the communication is thoughtful in like a discharge summary, that it highlights the behavioral issues and doesn't just bury that. So that was one thing I heard you say. So if you could say anything else you want to add to that. And then the last one is just basically, does insurance pay for TMS?
oh, great question. From the communication standpoint, I would say again, this really needs to be tailored to your particular culture in your practices. The culture at Mayo Clinic is, don't be hesitant to pick up the phone and call your colleague, or send them a work email. And usually, like within 24 hours, most of our colleagues will respond back to my question about a patient care, either by work email or by any sort of communication. So communication that needs to be like tailored. I pick up the phone, talk. I sometimes call the nursing home that a patient came from, and I'll be very kind and ask the nurse who is caring for the patient, because they are still caring for patients on the ground there. They are very busy, and acknowledging that, I would really probably, like, I haven't begged for their few minutes of time to help me understand the patient that I have of theirs, to better understand their behaviors. Right, that makes a difference. It's on us as a care team together caring for this patient, to identify what works and taking that extra effort. I wouldn't say like, hey, this is simple, easy. This is more work. This is more complex. But I think when we are caring for these patients, we have to commit for it and be dedicated to getting that information, because that information will make a difference. Without that information, I think we are only shooting darts in the dark. So, and it is not helpful for the patient, not helpful for the care team either. So communication is the key. In terms of TMS and insurance, like right at the top of my head, I think TMS is still in the research phase for the BPSD symptoms. So I do not believe, I do not know at the top of my head like how much is covered and what is not. So I'm not an expert, insurance expert in forms. We have used it here specifically as part of research projects. And for those studies, we have not charged the patient anything at all, because it is all part of the research study that is funded from the.
Thank you for tackling that question. Thank you so much, Dr. Pagali. And just for everybody, I'm just putting some extra offerings here. If there's more educational opportunities or information you want on any of these programs, which are kind of, we're all in a family here. You'll get the CME link. The webinars and slides will be posted. The webinar recording and the slides will be posted Monday. And Dr. Pagali, I just want to end on saying thank you so much, because you really, I think, you clearly hit on a topic that many people are interested in, and really gave it like such a thorough treatment. And I think really helped us understand the importance of quantifying this issue and really addressing it with all the tools in our toolbox by doing so. So thank you so much. Have a wonderful day, everybody. And thank you again.